Okay, so I'm going to just briefly read the bios, and then we have some questions. We have some questions from the board that will be asked, and then we'll open it up for some of the membership, see if there's any questions that you guys have. So I will start with Dr. Patricia Wilkerson-Uddyback, MD, MPA, FSAT, who is the Corporate Vice President of Academic and Community Affairs, Detroit, at the Detroit Medical Center. She's currently the Corporate Vice President of Academic and Community Affairs at the Detroit Medical Center, which I just said, hello. Okay, she's responsible for the oversight of all resident and medical student education across the Detroit Medical Center. Her career in medicine began over 30 years ago, and she has held various leadership roles at the DMC, including Chief of Emergency Medicine at Harper-Hudsall Hospital, Interim CEO, President of Harper-Hudsall Women's Hospital, and Chief Medical Officer for Detroit Receiving and Harper-Hudsall Hospitals. Dr. Wilkerson-Uddyback is a board-certified practicing emergency medicine physician. She graduated from Michigan State University with a BS in Lyman-Briggs Physiology and completed additional coursework at Brown University, Harvard University, and the University of London in England. She received her doctorate of medicine from Wayne State University School of Medicine and completed a combined residency in emergency medicine and pediatrics at Detroit Receiving Hospital and Children's Hospital of Michigan with the Detroit Medical Center. She's also completed an executive MBA from the University of Tennessee, Knoxville. So welcome, Dr. Uddyback. If you could raise your hand so everybody sees you that you're here, welcome. And then we also have Dr. Sharon Miller, who she does obstetrics and gynecology through DMC Sinai Hospital. She has a Doctor of Medicine degree from Michigan State University College of Human Medicine in Lansing. She has a Bachelor of Science from Purdue in West Lafayette, Indiana. So her experience, she presently is an OB/GYN physician with the Wellness Plan, and she provides women's health care, including low and high risk obstetrical services, gynecological, preventative care, and surgery as indicated for chronic pelvic pain, uterine fibroids, and abnormal bleeding problems. She performs in excess of 200 deliveries, intensive gynecological operating schedule, scheduling obligations, educates residents and medical students in OB/GYN. She's also, it says, attending physician, Ascension Providence Hospital, Southfield, Michigan, and assistant clinical professor at CHM MSU, September till 1995 to the present. She's contributed to the learning environment that encourages knowledge and development of skills, advise and teach OB/GYN residents and medical students from CHM at MSU, and provides quality care to all patients to include consultation, diagnosis, treatment, education in accordance with healthcare guidelines and principle of practice. She participates in low and high risk obstetrical care, performs the surgeries, and practice evidence-based medicine. She received the Silver Award for 25 years of service in 2020. She received the Clinical Faculty Teaching Award in both 2017 and 2018, and the APGO Excellence in Teaching Award in 2011. Affiliations: American Medical Association, National Medical Association, Detroit Medical Society, and Michigan State Medical Society. So first, Dr. Miller, welcome. If you could raise your hand as well so everybody sees who you are. So I'm gonna turn it over to the board. We have to have one of the board members ask we have some questions that we put together. So is Amber on there? Is Amber still with us? I know she was driving. Okay, if Amber is not, I'll just ask the first questions for both of the doctors. What are your 5 tips for Black women as far as their health? And we'll start with Dr. Wilkerson-Uddyback and then have the response from Dr. Miller as well.
Well, thank you very much for having me today. I think this is a very, very important topic. And I just want to say, again, thanks to you and to my good friend, Alicia. And I see one of my church members on here too, Attorney Rita White. It's good to see you. So So from my perspective, it's very simple. The 5 tips I would give all of you all is number 1, sleep well. Make getting your rest a top priority. And I know who I'm talking to. Probably the majority of you don't sleep as many hours as you should. The recommendation is 7 to 8. I don't know if anybody out there can actually get to 8. If I get 7, I'm feeling pretty good most nights. I would also encourage everybody to eat well. I mean, that goes without saying. And most importantly, avoid sugar. If there's only one thing you can do, avoid sugar. Soda pop is the devil, just straight up the devil.
Okay.
And don't fool yourself if you're thinking you're doing better by drinking diet sodas or Coke Zero. I have a little bit of a penchant for Coke Zero. It's bad, 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 bad. So eat well, move. I don't care what you do, just move. Don't sit in your easy chair, move. I don't care if you're walking. I don't care if you are getting out doing gardening, move. Learn your family history. This is something that I don't think we really understand the importance of. Know your family history. And for some of us, that's a little bit harder to do because, you know, back in the day, we would die from things and they said it was natural causes, or, you know, because of institutional racism, we never really got the due diligence or the workups that we should have. So we may not always know, but do your best to find out what your family history is, because that can sometimes then direct you in terms of things you're going to need to do preventative wise. And then nurture your relationships. So sister friends, groups like this, your community is definitely tied to your longevity. There are many, many studies out right now, particularly looking at blue zones, which are areas in the world where the longest living humans live. And the one thing that is common in all of those is they have really tight-knit communities. And so loneliness, in my opinion, is one of the top things that is going to be plaguing us, especially with COVID and everybody being isolated. So nurture one another, nurture your families, do whatever you got to do to connect, even if it's via Zoom. That does something to make sure that you're staying connected with the people that matter most. So those are my 5 tips.
Okay, and then Dr. Miller.
Thank you, Robin, for having me, and to the Black Women Lawyers Association of Michigan. Thank you for the opportunity. It's funny, we both had some very similar thoughts on these 5 tips. I have be mindful and meditate. I have to stay active and have movement, to eat to live and eat healthy and watch your nutrition. Sleep well, rest your mind and body, and always show gratitude and appreciation for things and what you have, and your patients and the people, your clients, your coworkers, as she mentioned, your family members. And I have maybe one more, which was to recover and re-energize from the day. But I do think it's important that we pay attention to these things and we're mindful of these things and we practice them on a daily basis.
Okay, and then from the board, I know we had come up with some questions. Does anybody from one of the board members want to ask the doctors a question from our list?
I have a question. It's basically the second question that's on the list. However, I would want to incorporate that, you know, according to the American Heart Association, cardiovascular diseases and stroke, that incorporate stroke, along with autoimmune diseases, and cancer are one of the top diseases that are affecting African Americans, especially cardiovascular disease. It indicates nearly 50,000 African American women annually suffer from some type of cardiovascular disease. Mm-hmm. Now, can you provide more understanding on these ailments, along with known conditions that Black women are known to have a high rate of in terms of diagnosis, and what can Black women do to focus on prevention and focus on basically being aware of their symptoms?
Okay, and with that, we'll start with Dr. Miller and then we'll go back to Dr. Wilkerson-Uddyback.
Thank you. So I agree with you that the number one issue is heart disease. The rates are very high, but it definitely has a very high morbidity and mortality. You're absolutely correct. Followed by cancers of the breast and the cervix, And thirdly, I agree with you that stroke is a huge concern. I think that we can lower our risk, particularly for heart disease and for stroke, by some of the things that we talked about in our tips. So for example, trying to monitor our weight and lose weight, trying to eat healthy and watch our diet, to not smoke if we have a tendency to want to do that, to increase our physical activity, and of course, to decrease our stress as much as we can, so that we might have a positive impact, for example, on our blood pressure, to watch the salt that we take in. These are the things that I think we have to focus on and look at, because we know that diabetes is, very common in African-American women. Obesity is very common in African-American women. And so those things contribute to the heart disease rate, the stroke rate. And of course, as an OBGYN, obviously the cancer issue is near and dear to my heart in terms of breast cancer screening and cervical cancer screening, particularly in the month of October, where we raise consciousness and awareness and talk about this is breast cancer screening and awareness month. And so we all want to talk about it. It's far more mortality in Black women, and we have to really push for screening for the breast and cervix.
Okay,
And
so Dr. Uddyback?
yeah, I'll add, Dr. Miller and I, we are definitely connected souls here. So just to piggyback on some of the things that she's already shared, I'm going to go back again to knowing your family history, because there are definitely some things that you're predisposed of, depending on what your pedigree is. And there are some things, depending on your history, that you need to be even more diligent about than just normal. If you have a strong family history of colon cancer, then you may need to start getting colonoscopy sooner than the recommended age of 50. You may need to get them starting in 30, 35. If you've had somebody in your family die from heart disease at an early age, and I mean under the age of 50, then you may need to start getting screening quicker than normal. You can't wait the normal time frame. You have to be more diligent. The other thing that I'll tell you is get a doctor. If those of you on this call, if there's anybody who does not have a physician, that's the first thing. And I'll tell you why it's even more important for African-American women to have a physician. We all know, and if you don't know, I'm gonna tell you now, we are the victims of institutional racism as it relates to health care than anybody, any other race or nationality. We walk into the emergency room where I practice, and you're gonna be more likely to be dismissed or disregarded in terms of the symptoms you're gonna present with. So if you start the process with your own physician who knows you, who you've engaged with, who you trust, then you're gonna be less likely to have your symptoms or issues dismissed. So that's the first thing I'm gonna tell you. Get a doctor and make sure you go to the doctor. Take your medications. It's not okay to not take them for a day or two. If you snore, if there's anybody out there and you've been putting off getting that sleep study because you don't wanna be bothered with a sleep machine, that's gonna increase your risk of heart disease and hypertension. So those are the things that you can do. And it doesn't matter how educated or intelligent you are. We all have this gift of procrastination that will plague us and cause us to have issues sooner than we need to.
Okay, from the board, do we have any other questions from board members?
I'd like to ask a question. We hear a lot as Black women about the issues of fibroids. What preventive measures can we take as Black women regarding fibroids, and why are they more prevalent in Black women than other ethnicities? And my other component to that question is the disproportionate number of fibroids in Black women associated with diet or something that is specifically unique to us?
Okay, I'll start with Dr. Miller on that one.
So it definitely is predominantly in the African-American woman. 40% of Black women have fibroids. It's still really being researched as to why that is the case. But I will say that some of the largest fibroids I've seen in my career have been actually in women who are African in Africa at the moment. I've had them present with fibroids that made them look as if they were a term pregnancy, for example, which is unusual for them to be that large. It is a very common condition. It is something we see all the time. There are lots and lots of treatments in terms of trying to sort out why they're more common in African-American women. You know, they've looked at diet, they've looked at weight, they've looked at genetics. It's still being really sorted out. But 40% of African-American women have fibroids and present with bleeding, pain, discomfort with intercourse, low back pain, a myriad of symptoms. And the beautiful thing is the 25 years that I've been in practice, there are more and more treatment options. There's more and more things that we can do to conserve the uterus. Whereas when I started in practice, almost everybody got their uterus removed, which is a hysterectomy. Now there's some techniques and procedures that can spare and conserve the uterus for women who have not had children. And I'm excited about those new technologies. And there's hope for that. So I think the most important thing is if you are having those symptoms, you see a gynecologist. If you aren't sure, then you see the gynecologist and you request a pelvic ultrasound so we can see the size and location of the fibroids. And I think it's just about, you know, like Dr. Uddyback said, getting in and having that surveillance and having a physician that you're comfortable with.
Okay. And Dr. Wilkerson-Uddyback, did you want to weigh in on this question as well?
No, that's definitely Dr. Miller's area of expertise. I ditto what she said.
Okay.
Thank you.
And then so, well, I'll turn back to the board. Do we have from the board members, do we have any other questions specific questions you want to ask?
Yes, this is I guess maybe like a 2 or 3-fold question. Vaccinations. Okay, so now we know we have the actual vaccinations in place, and now we also have the boosters. Now, there's been a lot of talk about there's still a percentage of individuals that have not been vaccinated. And we have also heard about people that have received the breakthrough, meaning they've obtained, had been diagnosed with COVID after receiving the vaccination. Can you please provide your position on vaccinations and how we can really balance out individuals separate that don't really want to focus on the science, but they want to focus on social media or their own research and make their decision that way? How can we really, what's your position on the status of COVID, and really, how can we help balance it out so people can really have a full, true understanding of the seriousness of this situation, this disease?
Okay, well, that would start with Dr. Wilkerson-Uddyback.
So yeah, this one definitely hits home for me, especially still practicing. First and foremost, I just want to say, if there's anybody out there who still is on the fence about getting vaccinated, please reconsider that decision. I will tell you right now, there is not a hospital system in this area who is not challenged with staffing at all levels that not only will compromise the care you receive in any department you go in right now for COVID, but anything else you go in there for. So if you're going there for a stroke, a heart attack, an accident, the chances of you receiving care that is not quite at the highest standard that you're used to is very, very high right now, just simply because we can't get nurses to take care of patients. So that's first and foremost. And that is definitely something that is a phenomenon related to COVID. So I got to put a plug in there. This vaccine, the technology that was used to create this vaccine has been around for over 30 years. And as a matter of fact, the Moderna vaccine was developed by an African-American PhD physicist, Dr. Kissimmee. I'm blanking on her name right now, but she helped to develop the technology to create the vaccine. People will always say, oh, Dr. Uddyback, it was developed so fast. I mean, I deal with these questions all the time. Yeah, it was developed fast because we needed it. The whole world was focused on it. So don't worry about how fast it was developed. The technology has been around for 30 years. And when you have something so critical where everybody's resources, both human intellectual resources, as well as their financial resources was focused, well, of course, you're going to get something quickly. Social media is the devil right now. I'm gonna say it again, because it's so much false information out there. We've had vaccines for as long as I've been alive. I don't know how old many of you are, but if it were for vaccines, we would still be dealing with smallpox. We would still be dealing with polio. This is really no different than that. The facts about this vaccine are this: it cannot give you COVID. It is a non-live vaccine, okay? The virus is not part of it. It takes a small piece of the protein from the virus, and it develops a protein that, once it's injected in your body, stimulates your body to make antibodies. The best thing that the vaccine does for you, even if you get the virus, and you still have a chance of getting the virus. So that's not really the main reason we want you to get it. The main reason we want you to get it, obviously, is to prevent it. But one, if you get that virus, you're not going to die, and you're not going to have to be hospitalized. Those are the two most important things you need to focus on. If you get it, you're not going to die, and you're not going to have to go to the hospital, period. And I have many, many, many friends of mine now, because those of us who got vaccinated in the earlier days, the studies are showing that some of the antibodies are starting to wane, which is why everybody is rushing to get the booster. I got my booster. But even when they've gotten the virus, even now, they still didn't have to go to the hospital. It was a little bit like having the flu when they got over it and they moved on. So that's the main thing. Lastly, until all of us are vaccinated, we're going to continue to have variants, okay? The Delta variant is the most common one right now. We're monitoring the Mu variant. It's a variant of interest, which just means they're really watching it closely. It is not prevalent in the United States right now. It was originally seen in Colombia, and it hasn't reached us yet. But I will just say that until we all get vaccinated, we're going to continue to live the way we're living right now. This is not going away until we all get vaccinated. I'm just going to tell you, period. No, the variants will continue to develop, because that's what viruses do. They mutate, the survival of the fittest, and new variants will come. Hopefully, the ones that are out there right now, the current vaccines that we have available in the United States, which is Pfizer and Moderna, are effective against them. But there's only a matter of time before there's going to be a variant where we're going to have to get a new vaccine, which is what happens. You know, that's why we have to get a new flu vaccine every year, because there are different varieties that come up. So I'm definitely pro-vaccine. I think that the strongest thing you can do if you are pro-vaccine like me is to just tell your story to people. And I'm sure all of you all have family members or friends who are like, I ain't getting it, I don't care what you say, Uddyback, I ain't doing it. I talk to patients daily. You can't make me, I don't trust it. They're trying to put a chip in me. You know, it definitely isn't tied to racism, because we die at greater rates from the virus. And it tells you something when Israel was the #1 country to get vaccinated before anybody else. So that tells you right there, no, the vaccine itself is not a racially motivated thing. But I will just say that until we all reach that point where we're at least 70, I'm going to say 80% for real herd immunity, we're going to continue to live this way. And I'm just kudos to all of you all who are still being cautious. The best thing you can do, even if you've been vaccinated, is continue to wear your mask, continue to be cautious. Social distancing, those things work. Those of us, I can just tell you from my own emergency group, we had very, very few people who actually caught the virus, even though we were in the midst of the madness at the very beginning, because we practiced very, very strict PPE guidelines, meaning that we wore our masks, we were wearing our protection. You know, for us being in the ED, we wear goggles, and that measure in and of itself caused our group to have a very, very low rate of COVID. So those things work. The PPE, the mask, it works.
Okay, thank you, Dr. Wilkerson-Uddyback. I mean, we have Nurse Pam, my mom is on here. She's been saying the same thing that you've been saying about, she's like, until everybody gets vaccinated, the variant is gonna keep going. And she's been saying that. Okay, Dr. Miller, did you want to weigh in on the vaccinations?
I agree with everything that Dr. Uddyback said. I just want to say that the American College of OBGYN does support the vaccination for pregnant women, supports the vaccination for breastfeeding mothers, and supports the vaccination for people who still have not had children. It has not been shown to have an impact as far in the testing that they've done on any type of fertility issues. So the American College of OBGYN, myself, my colleagues, we are in support of women being vaccinated. We have had a number of pregnant women with COVID. We just discharged a patient today that had COVID. So pregnant women are very susceptible because their immune system is lowered to tolerate the baby. So it is important that pregnant women understand that they should be vaccinated. I encourage patients, I've read literature that suggests that if doctors suggest to patients that they should be vaccinated, that it does carry some weight with them. I try to address it with every patient that I see. And I agree with Dr. Uddyback. It's going to take time, but we have to keep encouraging people to look at the science of it and not the internet and social media, and just really follow the science of it, because she's absolutely right. You want to eliminate the strain on healthcare and people and their families by not having people fill the ICU with patients with COVID. Because then when you have a heart attack, or you have to have a bypass, or you have a stroke, or you have something else, a catastrophic accident, there's no beds available for you. So it's just to look at the good of all of society. We have to encourage our friends, family members, colleagues to be vaccinated.
Thank you, Dr. Miller. Again, I've said it. I've said it on social media. I've been vaccinated. I got Moderna. Yes, I was hesitant. A lot of people have been hesitant. But I mean, I do criminal defense, so I'm exposed to the public, to me, when I heard that we were going to be opening up having some limited court hearings, I was like, okay, I'm going to take it. I'm going to pray on it. I'm still taking my, supplements, zinc, turmeric, elderberry, but I mean, and I'm waiting on the booster. So Dr. Miller, I do have a question for you specific as it relates to, you were talking about pregnancy. So if you're in your 20s, 30s, or 40s, and you plan to get pregnant, what should your focus be? And also, before you answer that, I want to give a shout out to my best friend, Dr. Marcia Baker, who is a fertility doctor who is joining us from California.
Wow.
So I asked her to come and join in and be a part of this discussion. So yeah. So, okay, Dr. Miller, now pregnancy,
Yes.
because we're lawyers, we're busy. There's some of us in our 40s, we want to get pregnant. And I don't know, I know we had one of our other members had said a few years ago, like, hurry up and do it, freeze your eggs. And I mean, so, so what can you enlighten us with as far as this issue about pregnancy?
Well, I can definitely say to you, working at the Wellness Plan, which is a federally funded clinic in the city of Detroit, I see the teen pregnancies and I see the 20s and 30s quite a bit on a daily basis. I think the 20-year-olds do well. I mean, they do really well. I think the teens, that's a whole nother issue, and I'll save that for another day because there are tremendous challenges. But 20s through up to 30, the 30-year-olds, I think their biggest thing is they have to realize they have a little bit more increase with gestational diabetes and a little bit more increase with hypertensive disorders like preeclampsia. So we watch them a little bit closer. And as we get older, because we're born with our eggs, they're influenced by everything that we are influenced by throughout our lifetimes. There's a little increase in the chromosomal disorders in terms of Down syndrome, and it goes up by the time you're 35. We talk about 1 in 200 chromosomal abnormalities. So I think you have to be aware of that as you're in your 30s. And then in your 40s, I just a couple weeks ago delivered a 49-year-old first baby. So there's definitely older women having children in their 40s. I think you have to, again, recognize you're going to have a little bit higher risk of diabetes. You're going to have a little bit higher risk of hypertensive complications with preeclampsia. And you also have a big bump in the risk for Down syndrome, trisomy 18, trisomy 13, the chromosomal disorders. At the age of 40, you're up to about 1 in 50 with Downs and other chromosomal problems. So the beautiful thing now, the technology has evolved over time to allow us to do what's called cell-free DNA testing. And so now a lot of these patients in their 20s and 30s will have cell-free DNA testing, which is about 99% accurate in terms of looking for chromosomal disorders. It saved a lot of women in their mid 30s to early 40s from having, we used to do amniocentesis on all of these patients, or at least offer it to them. And now you just have a blood test that looks at cell-free DNA as a screening tool, and only really our patients that have abnormal cell-free DNA having to go for amniocentesis, which is obviously a little bit more invasive. So I think that advance has really helped us in the field of OB, and certainly would defer to your friend in terms of the fertility issues as it relates to women who are aging and decide to defer having children until their career is where they want it, in terms of when she would recommend. I don't really participate or get involved in the freezing of eggs and all of that, but I know that she would have some recommendations on that, and I would respect her opinion.
Okay, thank you, Dr. Miller. Dr. Baker, did you want to weigh in on that?
Yeah, let me give my opinion. Can everyone hear me okay?
Yes.
Okay, good, good. Sorry, I'm driving in my car running a few errands, but I wanted to hop on to this event. Thank you, Robin, for sharing the Zoom link with me. I really appreciate it. And welcome everyone. So just a couple of comments as it relates to fertility in our 30s and 40s. So as we know, there's a natural decline in fertility that happens in the mid-30s. It particularly accelerates between ages 37, 38, 39 into 40. So with that being said, for many women, when they start making decisions about pregnancy, they do take into account, particularly professional women, certain markers in terms of their professional achievements and attainments that they would like. And usually you have to remember the goal post for these significant career attainments typically happen in the mid-30s, early 40s. And so the ability to wait until all of the professional achievements are attained can be fraught with a lot of difficulties on the fertility front. And oftentimes, as fertility specialists, we see patient populations of professional women in their late 30s, early 40s for this very reason, that they've deferred childbearing so as to attain their career goals. I really think we need to have a paradigm shift in terms of how we see fertility for the professional woman. And I tell my patients, just as they are very directed about their professional journey, they have to be very focused and intentional about their fertility journey as well. Understanding that there is a true biological clock, and understanding that it is more prudent to start the fertility journey at an earlier age as opposed to a later age. The reality is we do have a fertility window, a time frame with which we can utilize our own eggs. And going beyond that fertility window, then the option of something called donor eggs becomes a discussion that we have with patients once they're outside of that fertility window, which usually ends up being around ages 43, 44, and so on. So what I do want to say, just as a word of advice to the professional women who are on this phone call and on this Zoom, just to say it's so important to be intentional about the fertility journey. It's hard when obviously you may be waiting for the partner to come in to the fertility picture. So the benefit of fertility preservation options like egg freezing or even creating embryos with like a sperm donor, those are options that are available for patients that I think many women are not aware of, just because they're not really topics that are discussed with a lot of freedom within our community. So my best advice is, not to wait too long. If you are a young professional woman in your early 30s, you should be having conversations with your general OBGYN about what your pregnancy plans are. Hopefully you have made a decision about pregnancy planning by the time you're 35, whether it is to proceed with having a child or to pursue fertility preservation. So please, please, please just don't wait until it's too late. That's what's so heartbreaking when we see patients who come to our office who really have just waited beyond their fertile window timeframe. So that is my best advice. But start first with your general OBGYN, start having that conversation. And then if you want to pursue additional testing, you can always ask to be referred to see a reproductive endocrinologist or infertility specialist in your area.
Okay,
That's
thank
my
you,
2
Doctor.
cents.
Thank you, Marcia. Thank you, Dr. Baker. Marcia, you're welcome. And I know when you get stationary, put your information in the chat, or of course I have your information if anybody has any follow-up questions. Dr. Wilkerson-Uddyback, question I have for you is, so you're in the emergency room, and what are the most common ailments you're seeing for Black women that are coming into the emergency room as of right now? What are we seeing?
Well, we see a lot of vaginal bleeding. So a lot of times I'm calling our OBs that are on call because we have a lot of dysmenorrhea or abnormalities with periods, or, bleeding when women are pregnant. I see a lot of that. I see a lot of women coming in with just basic cold-like symptoms, need medications refilled. And again, this ties back to making sure you have a private physician, because sometimes, for whatever reason, I know COVID threw everything off. There were offices that were closed and people couldn't get in, they couldn't connect. But a lot of times I see a lot of things where, I didn't get in to see my doctor. My prescription ran out, their blood pressure's through the roof. And so they end up coming to see me. And I do see a lot of people coming in still with the usual chest pain, problems with breathing related to asthma or COPD, strokes. We still see quite a high rate of those, unfortunately. So those are the things. The blood pressure is probably one of the highest ones. A lot of it lately, more than the feeling, I don't have any data, is a lot of high blood pressure related to stress. This pandemic has really stressed people out at a whole nother level, either from the isolation, the loss of loved ones or friends, close friends and family, issues with employment, even though it doesn't feel like we're seeing it because everybody has a help wanted sign in their windows. But that has really plagued a lot of people, more so than I've ever really seen before during my practice. So those are kind of things that I see. And COVID, I mean, people who are concerned about COVID, but not as much as at the beginning of this. It's really more, I think, bread and butter stuff.
Okay. All right. Thank you. So do we have, I've asked some of the questions, or the board's asked questions. Do we have from the members? Does anybody have a question for either of the doctors? Judge Miller, I see you have your hand raised.
Hi, actually, I have one for each of you. I'll start with my wonderful sister, Dr. Sharon Miller. And Sharon, I've heard you talk a lot to different groups about sexually transmitted diseases. And that is a hot topic in the state of Michigan and in Wayne County. So I'd like for you to address that. And Dr. Uddyback, I would like for you to address the differences that you all see in terms of presenting conditions for women when it comes to heart problems with the heart. A lot of women, we tend to ignore different signs and symptoms because we're thinking, oh, that's not my heart, it's over here. And I know you see a lot of that as well. So I'd like for you to please address those. And thank you so much for all the information you've both provided thus far.
Thank you, Judge Miller, for that wonderful question.
You're welcome,
Sexually transmitted diseases are like something that I see every day. And I'm so glad you brought it up because it was on my list of things that I wanted to touch upon. Because Black women are more affected than other groups, particularly as it relates to gonorrhea, chlamydia, syphilis, and unfortunately, HIV. So in Black women, it's almost 3 times more Black women affected with HIV than white women. I guess the biggest takeaway message for me and what I tell my patients literally on a daily basis is to 1, please get tested, and 2, please use condoms. I'm sad to say that I had a 26-year-old African-American woman in my office just this month who tested positive for HIV and syphilis. It is a real problem. And I think because it isn't talked about a whole lot, people think that it's not out there. it still is out there. It's still a problem. And if I just had an infinite amount of money, I swear to you, I would drop condoms all over the earth, because it really is a preventative thing. And the other thing I have to touch upon really quickly is the HPV Gardasil vaccine. I neglected to mention that we really, really have to encourage our patients, our friends, our colleagues to be vaccinated against the human papillomavirus, which we now know is what causes cervical cancer in women. And the FDA has increased the vaccine availability from the age of 9 years old to the age of 45 years old. So if you are less than 45 years old, you can now get the Gardasil vaccine, which covers 9 strains of the HPV virus. And it's very important for the prevention of cervical cancer. And like Dr. Uddyback mentioned, if we can really go aggressively and vaccinate women and men, boys, against the HPV virus, we will see the effects that we have seen against polio and smallpox, because we can do it if we really are assertive in pushing patients to be vaccinated against HPV. So thank you, Judge Miller, for mentioning that. Near and dear to my heart cause.
Okay, thank you, Dr. Miller. And Dr. Uddyback, did you want to weigh in on the question?
The only thing I'll say is that's something that we see quite a bit of too in the emergency department. And I think her words are spot on. I totally support what she said in that regard.
Okay, and then I see our attorney, Angela Williams, has a question.
Oh, I think Judge Miller had also asked about the cardiovascular issues.
Oh,
yeah.
okay, let's have the cardiovascular question responded to, and then we'll go to Angela.
So, we present in much different ways than the norm. So the normal presentation for a heart attack is, pressure-like feeling on your chest, shortness of breath, sometimes dizziness, the left arm getting really numb and heavy. Those are the classic symptoms that we read about in our textbooks. But when we come in, a lot of times we may just have heartburn, or we may have indigestion, or we may have pain on the right side. And it's like, well, that doesn't, it's like, wait a minute now. So those are the kind of things that we come in with, and then we're easy to be dismissed. Again, I can't overemphasize. I know you all know because of who you are, but structural racism is real. And the dismissal of African-American women and their complaints, thank God now is coming to light at a whole nother level. And it doesn't matter how educated you are. Doesn't matter that you're an attorney, you will still get dismissed like everybody else. So I think it becomes very important for you to understand yourself and really be in tune with your body. And again, I'm gonna go back to making sure you have a regular doctor that you're seeing regularly. I know Dr. Miller is probably a lot of people's regular physician because a lot of us rely on our OBGYNs until we, reach menopause, which is fine. I mean, I still say get a regular doctor, but some doctor is better than no doctor because she's going to pick things up, but you got to see somebody. And then knowing your family history. If you're at risk for heart disease, hypertension, if grandma had hypertension, most of our grandmothers and fathers did, or they died from a heart attack or had a pacemaker, then you got to go get checked out.
Okay, now Angela, you had a question?
Yes, I do. Thank you. And actually it kind of piggybacks on just what Dr. Uddyback said. A few years ago, my OBGYN, Rebecca Williams, retired. And I had tears in my eyes. I felt like I had been abandoned. And the reason being is because my experiences have been cultural. And OBGYNs that were of another persuasion, and I'm not necessarily. I've never had one that was Caucasian, but from other countries and other cultures. And that any complaint I had was dismissed, and as she said, it didn't matter whether I was an attorney or not. It's just, why is this black person, this black woman complaining? They all have the same complaints. Yeah. And that was the attitude. Well, I had found Dr. Williams. Well, the Ford system. I found her. And then she disappeared on me. And my sister was telling me that she had this wonderful OBGYN, just happened to be Dr. Williams. So ended up back with her and then she retires. So my question to you is there a network of African-American OBGYNs that can be to other Black women, just like myself? I mean, even at the point when I was going through menopause and on the other side, I still found having OBGYN beneficial to me. I've gone someplace else, but I did not have the same type of concern and care that I did with Dr. Williams. She explained things to me, explained to me why weight gain was may have been problematic and some of the issues I was having, why it was important for me to try and lose the weight. And I mean, sometimes she's talking about tightrope. So I think it's all important for us to connect with somebody that we know cares about and understands our bodies as Black women. So is there a referral or organization network that we could connect into? Because even if you belong into a HMO system, whoever they refer to is not necessarily someone that you may want to go to. Or they may refer you to somebody that you may like, but they're so inundated with other patients that they really don't have actually, take care of you as a patient.
Right. So Dr. Miller, if you want to respond, and then Dr. Uddyback, is there like a referral list for African-American doctors or OB-GYN or family general practitioners?
So I want to just first say that Dr. Rebecca Williams was one of my partners.
Okay.
And we were in a group together called Women Caring for Women.
Okay.
She was a wonderful provider. And like you, I was very sad when she retired.
No question.
The beautiful thing is in Metro Detroit, we are very, very fortunate to have a number of African-American OBGYNs. Particularly, I practice at Providence. We have probably 12 African-American women in the core part of our faculty here that do the most births here, particularly at the Providence and Southfield. I also have privileges at Sinai Grace, and I know that Sinai Grace also has a tremendous number of African-American providers, as does Henry Ford Hospital. So we're very, very fortunate that there are a lot of African-American OBGYNs. Some of them are my age and older, and some of them are younger. And the beautiful thing about OBGYN right now, and it has changed over the years, is it's a predominantly female specialty. When I trained, of course, it was not, but now women in my residency program at Providence, 20 residents, 19 women. So women are running this field. It's just the way it is. And there are a lot of minority providers out there that are absolutely fantastic. So I'm happy to give you a list of my friends and the sisters that I know that do this on a daily basis that truly care about patients.
Great, because I'm in your system.
Okay, great,
Okay.
great.
Yeah, no,
So,
that I agree. I echo that. I think I think it makes a difference when you have, it's about a cultural competency. So I definitely would welcome a list of referrals, for Black female, Black attorney, not Black attorneys, Black doctors, because Black doctors. Dr. Uddyback, did you have anything to add?
I think, again, Dr. Miller and I, we're like sisters from another mother. I tell you, we are very fortunate. I tell residents this all the time, especially African-American residents, Detroit is very special that you have a lot of people to mentor you and nurture you in this area. That's not the case when you go outside these our city limits. So I too could provide, probably it's gonna be some of the same people, because I'm sure you know the same people that I do, Dr. Miller. Detroit's a very small country town. But what I would like to add to that list is a list of family medicine physicians and internists and some cardiologists. Now I'm gonna add the only female cardiologist that I know is Celeste Williams out of Henry Ford. There's probably a couple of more, but I know her personally. What I think I could do for you guys is give you guys a full listing of physicians in different specialties. OB for many of us is the number one person that we go to, but you may want to, you may need a cardiologist, you may need a gastroenterologist.
Exactly.
And I can definitely provide a listing of those as well.
Okay, yeah, that would definitely be appreciated. If you got that to me, then I could forward that on to the membership. So we keep it in the circle, as far as going to see our own, and
Yeah.
do we have any other questions from the membership, from our distinguished guest? Any other questions? Do we have any other questions from the board, for our distinguished guest? Okay, well, it's 4:40 and it's a Sunday, so I want to thank
Robin,
our distinguished panel.
I'm sorry,
sorry.
Robin, I'm sorry, honey. Edith has her hand up. I don't know if that's old or current, but.
Oh,
Hi,
Edith, sorry, Edith, I didn't see you. Go ahead.
That's okay. I raised my hand at the last minute. Hi, my name is Attorney Edith Blakeney, and I was invited by Chandrika. She actually saw me in court and reached out to me, so I really appreciate that. My question is, when we go to the ER, is there something that we can do to not present ourselves better, but to make our voices heard? I know recommending that we have a primary care physician was one of the recommendations, but what if we don't have a primary care physician, or what if they can't contact them? What can we do so we're taken seriously?
So I think the most important thing is to remain calm, even though, somebody may just try to dismiss you or say something that just gets you really irritated. And oftentimes, when you come to the ED, I always tell people that's not the highlight of your day, right? You never plan to go to the ED. You're usually not in the best state of mind or in the best mood. But what I tell people is to remain calm and remember you are your own best advocate. And so if somebody is trying to tell you, oh, ma'am, that belly pain you having is just constipation or stress, you're under a lot of stress, or dismiss you without really doing a thorough workup, then you have to really just be diligent to say, you know what, doc, I understand that, but this is not normal. I know my body. I'm not crazy. This is unusual for me. And you have to be diligent and persistent. And hopefully you get somebody who will then take another look or pause. Also, when you go in, have your medications, even if you don't have them with you, have a list of things so that you're not trying to remember, oh, I can't remember the name of that medication. It's a blue pill. Oh, I can't tell how many times I get that. It's a blue pill, doc. And I'm like, do you know how many blue pills it is? I don't know what blue pill it is. Have it with you at all times. All the medications you take, how often, if you're allergic to anything, just your history, have that available so that you can give them a very thorough understanding of what your background is. And they have everything available to them to really know what they need to do. But the best thing is to just be diligent and stand up for yourself. Politely, but do it. Don't walk out of there if you're feeling like, I know I'm not crazy. I know that this is not stress. And sometimes it is, but in my experience, stress is always the last thing on the list after I've worked up everything else.
Okay, thank you, Dr. Uddyback.
Thank you.
Dr. Miller, did you want to weigh in on that?
No, I agree. I think the emergency room is just, it's very difficult environment. I think patients often feel very vulnerable. As an OBGYN, we see lots of patients in the ER because we're dealing with, of course, miscarriage patients present there, patients that are bleeding from their fibroids or that have pain present to the emergency room, patients that have, like she mentioned, a mass in the pelvis. We see a lot, pelvic inflammatory disease, chlamydia and gonorrhea.
Yeah.
I mean, we see the ruptured ectopics. I mean, so much of what we do does come through the emergency room. We definitely try to call ahead. I think that what Dr. Uddyback said about having a physician that calls ahead, I could call her and say, hey, I'm sending in my patient. These are her complaints. give me a call once you see her. I think that goes a long way and patients
Yes.
don't realize it. If you have a primary care physician, internal med, family med, or OBGYN, they can call Dr. Uddyback and say, I'm sending my patient in. She's in tremendous pain. I don't know what's wrong with her. She's bleeding heavily. Can you please take a look at her and give me a call? You've got a connection there. She's going to be looking for you and she's going to give me a call. So I'm in the loop of what's going on with your care. And I think that that really helps.
Excellent advice.
Okay, thank you. So do we have any other questions from either the board or our members? Okay. For either of the doctors, is there anything that you wanted to add before we close? Anything that we've asked you, anything that you want, any other input you want to provide?
The only thing I would like to add, honestly, and I know that it's a huge topic, but I just want to end by saying we didn't touch upon mental health and mental illness, but I want to say that I know because I see it every day in my practice, African-American women are especially vulnerable, wrestling with mental health issues, whether they're sad, they're lonely, they're hopeless, they're worthless, whatever their issues are, whether they've had rape, incest, abuse, neglect. I mean, we deal with it, and I want patients and people to know that they have to talk about it. They have to be open about it. We have to address it to reduce the stress. And I think it's a huge issue. And I just want to make sure that patients know and clients and you guys know you have to bring it to us and we will help in any way that we can.
Yeah, thank you for that, Dr. Miller. Yeah, when we started our speaking series, we actually brought in 2 therapists last year, but I know we're going to be bringing some folks back. We brought in 2 African-American female therapists because actually right at the beginning of the pandemic, because we were just like, dude, this is intense. And it's already stressful enough being a Black person in America and then having COVID. So yeah, we definitely will be, we'll be looking to bring in some other specialist African-American females to come back and talk to us about mental health issues. And Dr. Uddyback, did you have anything else that you wanted to add at this time?
No, I think for me, I'm glad you brought up the mental health, Dr. Miller. That is really, really critical right now because, we tend to not necessarily think we always need therapists. Typically, especially professional women, you guys have accomplished a lot. You've dealt with a lot to get where you're at. But probably more than anybody else, we probably need to talk to somebody sometimes, just as much as the next person. But the last thing I just want to say is that just movement, making sure you're eating right, those are critical. I'll give one testimony. I started walking back in February because of Lent. So instead of giving up something, I said, I'm going to start walking 30 minutes a day. Now, I'm not an athlete by any stretch of the imagination. I really don't like exercising, to be honest. As much as I know it's important, I hate it. But I started walking. And I said to myself, I'm going to walk 30 minutes every day. It doesn't matter. I'm not getting on there to kill myself. I'm not, some days I walk really hard and some days I just get on to do it. But it has made such a tremendous difference for me. I used to say I always take my pressures and stresses to the altar, but now I leave them on that treadmill. So I would encourage everybody to start some type of exercise program. It doesn't have to be strenuous. You ain't got to run the, Detroit Marathon, but just do something at least 5 times a week to keep moving. That's going to be the best thing to keep you healthy.
Okay, well, thank you. I want to take this time to thank Judge Miller for recommending us over to her sister, and thank Delisha for recommending us over for Dr. Uddyback. But I want to thank both of you, Dr. Miller and Dr. Uddyback. Thank you for coming out. I know you guys are busy. It's the crazy time. As I said, I have my friend that's a doctor is talking about how busy it is. And thank you guys. We hope that you guys are taking care of yourself and being safe as well. Yeah. And thank you for coming out on this Sunday to be with us and have a blessed day, and everybody take care. Okay.
Thank you.
Bye-bye.
Bye-bye.
Thank you. Bye-bye.
Thank you. Bye.
Thank you. Bye-bye.